Welcome everyone to our webinar OHT implementation. People are all signing in. I see we have about 150 signed in so far, and we're moving ahead. I would ask everyone, this is the first time we're running this on a webinar. If you've been with us before, we've been in a meeting room, and so you see the chats right away. This time, we are in the webinar mode, and so I would ask that you chat into the chat box and say who you are, and make sure that you type to all panelists and attendees so that we can see. Yes. Denis Boileau. Bienvenue. Mark Robson, Ontario Health. Christina Bizance, you're going to see lots of your own team today from Southlake. Welcome to Sarah. And we're going to have a great event today. It's going to be a lot of fun, and I'm hoping we also learn a little bit. It'll be a great opportunity, I think, for us to really take another step forward in thinking about local evaluation. Welcome to Sonia from the GTA Rehab Network, Yannick Gay from Algoma. And everybody, welcome, and happy to have you all here today. And I encourage you all through our conversation today to continue to use the chat box to check in along the way. We're just going to start off with a quick little engagement. The first one is to ask whether you have been involved, joined us for a webinar before. Is this your first one, or have you joined us before? And you can see that we have about 57% are returning, and 43% are first-time joiners. Welcome to our event, and welcome to the community, and hope you will be back. So we are going to continue along now, starting with our land acknowledgement, and this is very important to us as we are all visitors here. So I just wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. We acknowledge that Canada is home to many diverse First Nations, Inuit and Métis people, and each of you today are joining us from one of those many traditional and treaty territories. Welcome. We're happy to host you here, and everybody is welcome as part of this. Today's event, we are going to have a great lineup of really interesting people talking about the real life, real world experience of moving to measures to support local evaluation implementation. Dr. Kaylee McKellar, many of you may know from our February webinar, is an evaluation expert with our team here at HSPN, and she's going to lead us through taking logic models and using them to help power your local measurement. And then we have a great team from the Southlake at Home team that's one of the OHTs, and this is one of their OHT initiatives. We have Judy Smith, a patient family partner, as well as Jennifer Andrachuk, Margaret, Furman, and Gail Seddon, all from this partnership that has taken place up at Southlake. And we think their approach to measurement and the importance that they've placed on measurement is a really good example for all of us. And so we're welcoming them to come and talk about their experience. And really, we're going to have conversation all throughout this next hour and a bit. And we'll start off with Kaylee, who will talk us through some of the focus on measures. And then we're going to move to the Southlake team for OHT implementation. Kaylee ran a webinar back in February of this year, and we were very interested in whether you took part in that particular webinar or whether you have viewed that online. And there are, of that webinar, it was actually our most viewed webinar that we've had since that event. So let us know if you happen to have seen that or participated. We have 125 responses. If you don't remember, click no. I will cut it when we get to about 150. 192 people have joined us now today, 193. I'm gonna end it off here and share the results out. And you can see that 30% have already seen that webinar, and 70% are going to be going online to watch it after today. So thanks for sharing. And that gives us a bit of a grounding now. Also, it helps Kaylee set up for her portion of today's event. And here's one more that I'm interested in knowing. And this is about your experience so far. We're going to be talking today about local evaluation and measures. And this is a little bit of a longer questionnaire, so I'm going to leave a tiny bit more time for doing this. And so I'll ask you, and you can check more than one option here. And we're interested in knowing whether you're involved in the measurement in an OHT initiative, whether you've been working on logic model but still need to work on the measures, if you went ahead with the measures and didn't really think about a logic model, you haven't done either, maybe you're doing other activities, and whether you are thinking, the last two questions are a little separate, and it really gets to whether you're thinking of trying to make best use of the ministry indicators, or whether you're primarily looking at measures that are locally driven. Here we go, sharing the results out. So the highest, the two highest groups here are people who are not directly involved in the measurement, and presumably that's other supporting partners from either organizations like Ontario Health or the ministry or RISE or our team, where we're not directly doing the measurement. And then some people are starting to work through logic models. But I also see here down at the bottom, using primarily measures that you've created locally. And I think you're going to find this webinar particularly helpful and useful if you intend to have local measures that are meaningful to your own OHT. And so you've come to the right place for that purpose. So I think now, without further ado, we're going to move on to a focus on measures for local evaluation. And Kaylee is going to come online and join us for this part of the talk. Kaylee, go ahead and you just tell me to move the slide.
Hi, everyone. So next slide. So well, I'm delighted to be here working with the HSPN team and back presenting. What I'll be speaking about today is 4 main topics related to program evaluation and selecting measures. So first, we're going to revisit logic models, then talk about developing evaluation questions, then measures to answer those questions, and finally, considerations for design and use of measures. Now, before I launch into these topics, I want to start by looking at why we aren't just talking about definitions and data. So on the next slide, we have a figure that shows the evaluation steps. Now, this is commonly shown in 10 steps, but I boiled it down to its core. And you can see that measure is there in the middle, and it's an absolutely pivotal and necessary part of an evaluation, but it is part of a full process. And it is common to start with measures, as we saw from the poll. Some people are doing that, but we really want to encourage you to look at what it is you're measuring and why. And one of the ways to do that is going through this process, starting with describing your program through a logic model and planning. So on the next slide, I'm going to first start with describing your program. So as Walter mentioned, there is a whole separate webinar on logic models that some of you saw, and I encourage you to check out. It includes a guide to actually developing a logic model. But on the next slide, I'm going to provide a brief overview to get us all on the same page. So what is a logic model? So it is a graphic depiction of the relationship among your program resources and activities and what you hope your program will achieve. Now, the figure there shows 5 common components of a logic model. And logic models do come in various shapes and sizes and should be tailored to your program. But what we have there is sort of the core elements. And you also want to make sure that you're clear about what your program aim or goal is. I will highlight that a logic model is different than a process map in that it goes further and includes outcomes and impacts. And in fact, when you're developing a logic model, we recommend that's where you start with the impacts and outcomes. So on the next slide, I'm going to walk you through an example logic model that I'm going to be building on throughout this presentation. So this is a hypothetical program and pulled from some things that relate to OHTs, but this program is looking to provide seniors with access to coordinated care to support improved health and quality of life. So our short-term outcome, we're looking at improving access to use of appropriate services for the enrolled seniors. This will lead into long-term outcomes of improved patient experience, improved symptom management, and improved independence. And we're hoping this all feeds into improved quality of life. So that's what we're looking to achieve, and how is this program going to do it? So on the next slide, we extend the chain, and we can see we're going to use digital resources. Our activity is going to be that we're going to screen all patients over 65 and enroll them. For our output, we have a target of a certain number of enrolled patients by next year, and they're going to be receiving the program in coordinated care. So this is one pathway of our logic model. We also, on the next slide, shows a more provider pathway. So this starts with resources of human resources. Our activity is going to be train teams on the program model and new standard of work. These teams are then going to follow the new standard work, and this is going to lead into the short-term outcome of improved provider experience and also feed into the more patient-centered pathway there at the bottom, looking at and allowing us to deliver our program to seniors. So now that we've looked at basically what a logic model is and seen an example, I want to touch on how logic models help with measurement. So on the next slide, there are 4 key topics I'm going to be going over. So first, on the next slide, is it helps us to identify processes and outcomes that should be measured. And this is to determine whether our program is being implemented successfully or producing the outcomes. So another bonus of this is that if we measure along this logic model chain, we can show that we're contributing to some of the impacts that we're looking to have, like health status. So second, on the next slide, we have that we can ensure the measures are relevant to the program, and that's by explicitly matching the measures to each component. And this helps us understand what the indicator is really telling you and what it isn't. And I will highlight that you don't need a measure for absolutely everything within your logic model. So third, next slide. It helps to distinguish between the short and long-term outcomes and which are feasible to measure and when. So shorter-term outcomes we're looking at as early as within a year. And I recently was reading about a visiting nurse program with a nurse visiting seniors, and mortality was the primary outcome. So very important outcome, no one will disagree, but the pilot was run for just over a year. So in this case, we want to make sure that we have some measures that we're going to see movement on early on. And so this might be, for example, immunization rate or flu shots. So fourth, next slide. We can use it to have support stakeholders in discussions and prioritizing measures. So the logic model is a great communication tool and can really support people getting on the same page in terms of what your program is doing and what success looks like. And OHTs are fairly complex programs, so you're going to expect to see a number of activities, outputs, and outcomes. But this can really facilitate discussion to looking at what is the critical pathway in your logic model, and you can focus your measures on that. So next slide. So the next step in the measurement process is planning, which involves determining what it is you're going to measure. So next slide, there are ways of prioritizing measures. One is looking at the critical part of your program, like we just discussed. The other one is looking at what you want to learn. So at this point, I'd really like to invite you to use the chat and share with us what it is that you would like to learn about your program. Or in other words, what are your research or evaluation questions? And again, please comment to all panelists and attendees.
And we're looking for really what's important to you. If you think about how you've been thinking about your OHT or your particular program within the OHT. What is it that you'd like to think about? And you sort of bring this question to mind today as we go through this webinar. And remember to type into all panelists and attendees, and it also gives us a sense of what other people are joining in. How to know if our priority activities are having the intended outcome? That's an important question. And that, you want to align the activities.
Satisfaction and services provided. Oh.
No, you go ahead, Kaylee.
So what difference does the new model of working together, the OHT, make? Good question. Connectivity to care. And what is the primary care engagement? I think these are all really important things to look at. And a key part is relevant to your program. What are your questions? Are we improving equitable access to care? Great question. Let's see. How do we know when it's working? Good, great. These are all really nice examples. It's good to hear from you.
Yeah, my sense here in looking at a number of these, Kaylee, is people really are interested in what's working and whether they're having intended effects, as well as what the outcomes are. And I just wonder if you have a comment here about both knowing whether the program worked, but also around thinking about how it's working, or if it's not achieving the outcomes, is it because of lack of implementation, or whether the implementation is going well? It's just there are other things that we haven't thought about in planning the programs.
Yeah, I think that's a really good point, and I will get a bit into, maybe I'll jump now into the next slide. So it's good to see that we have process and outcome measures, but yeah, what really drives us is, are we making a difference, right? But we also might have some questions in terms of, how can we be more effective to make that difference? And so those are the process questions. So both I would argue are important, yeah. Thanks everybody for sharing, really interesting, and feel free to keep sharing if you'd like. So again, evaluation questions, what we're talking about is what you, but also what you stakeholders want to know about the program. So it's a more inclusive question. So I just mentioned the process and outcome questions, and there's some examples here, and I'll just highlight really process questions are concerned with the implementation and the delivery. So a key example, and the classic example, is to what extent is our program implemented as planned? Why or why not? And as Walter mentioned, there might be some other things where you are doing everything you can in terms of implementation, but it's possible that there is some other contextual factor that's feeding in. So both are important to know. And then outcome questions, as we just said, it's an example is to what extent is the program successful? And again, it's what is the difference we're making? And this is really key because we want to know, are we helping people? Another question that I'll just highlight an example is what are the unintended outcomes? So OHTs are really learning as they go, and you might not be able to anticipate all your outcomes. So looking at these other unintended outcomes might be relevant. And the next slide, I recommend going through a process to develop questions. And again, this really needs to involve key stakeholders, including patients. And you can start by reviewing your logic model. Then brainstorm evaluation questions. You want to classify your questions. And I think here, this distinction between process and outcome is important. And it's really great to see that people are focused on the outcomes of what matters. But perhaps there's a balance. It depends on your program. You can also look at other themes that relate. So for example, you might want to look at your outcome questions and see how they relate to the quadruple aim. Then you're going to prioritize your evaluation questions and get agreement from stakeholders in terms of what is a primary or secondary question. And you can do this through holding a meeting with your stakeholders. Next slide, I have just some evaluation question checklist. So you want to make sure it's clear, specific, and well-defined. And as always, a high priority and aligned with stakeholder interests. Again, coming back to the stakeholders. It's measurable by the evaluation, and it focuses on a program or a component of your program. And by this, I mean aligned with the logic model. So on the next slide, I'm going to go back to that example of logic model that we had and see what are some questions that might align with this hypothetical program. So next, first question might be, are we providing sufficient training to staff and providers? And has provider experience improved? Next, we have questions related more to that patient pathway. So are enrolled seniors receiving coordinated care? And that's about sort of the delivery. And then that important question of, are enrolled seniors benefiting from the coordinated care? So what difference is it making? So as you see on this next slide, our next step is to look at what information or data do we need to answer these evaluation questions, and this is when measurement comes in. So I'm going to launch back into this example logic model, and just to highlight how we can look at the alignment. So the first measures there relate to that sort of provider pathway. So we can look at the number of training sessions held or the number of training participants. Related to our short-term outcome, we can look at the number of providers who felt the program made it easy for me to arrange access for my patients, and looking at those who responded strongly agree. So you notice that this is quite a bit more specific than what we have in our logic model. And also you can notice that not every box has a measurement. We're just selecting a few key points that we think are important. And then next slide shows a couple more measures, and these are more related to the patient. So in terms of our outputs and activities, we can measure the number of patients enrolled in the program, and we can look at the percent that are actively attached to coordinated care. So really showing that we're doing our part and we have sort of control over this. In terms of short-term outcomes, we can look at the percent of patients with primary care follow-up within 7 days of leaving the hospital and relating to access of appropriate services. For long-term outcomes, we can look at patients who felt their care was well coordinated, improved IADLs, and then finally for impact, improved score on the EuroQual. Now, I'm not necessarily recommending everybody do a diagram like this. The key point here is just to illustrate how you can show some alignment between your measures, your questions, and your logic model. So on the next slide is something that I do recommend, which is a table that allows you to look at all your measures together and get a bit more detailed. So one thing we can look at across the top is the logic model chain. Now, you don't have to have one of particularly everything. You might have more short-term outcomes, etc. So you can sort of tailor a table to your needs, but just highlight some key components. And I do encourage to put that part of your logic model, what you're trying to achieve, in the table. And often there's some things that are hard to measure, or you might need a proxy measure. So having what it is you're actually after is a nice reminder. Then you want to get detailed about what the measures are and their definitions. Make sure you know the data source, the extraction process or approach to data capture, and the frequency of reporting and audience. And again, this is something you can tailor perhaps there's other things you want to look at, roles of responsibility, etc. But I do encourage you to do this, to look at all the measures together. On the next slide, I have it populated with just a couple examples from outcome-related examples from that I showed earlier. So looking at the short-term outcome, so here we're looking at percent of patients with primary care follow-up within 7 days. And the data source for this would be using the EMR. We're going to need to partner with physician networks, and we'll use the DAD. What I mean by extraction or approach to data capture shows an example here. So some of these you might not already be collected or extracted. So for example, you might need to work with decision support to create a new process. And this will be looked at monthly by the steering committee. For the long-term outcome, we had improved patient experience. Again, with the measures, we're getting more specific in terms of percentage of response option, clearly defining it. The data source is a patient survey, and depending on whether this is done or not, it might be a new process, and you might need a team analyst in your team to create a spreadsheet and manage the data and do the polls. And this can be looked at quarterly. And then for the impact, we have health-related quality of life, improved score on the Euroqual through the EMR, and some of these things that you're doing are going to be routinely collected. And this can be looked at biannually with the steering committee. So that's just a couple of examples. I do want to get into, on the next slide, some key considerations in terms of measures. So one is to limit the number of measures, for example, 6 to 12, but there's no cutoff. One way to do this would be to, as we've talked about, align with the logic model and evaluation questions. But really you want to focus on measures that show if your program is achieving the objectives or signaling a problem. Now, I've underlined signaling a problem here because I want to highlight this, that we're all very invested in our work and we want to see it succeed, and it's important to measure and show successes, but it's also important to make sure we have the opportunity to learn from what we're measuring. And I did like that we heard from the ministry last year, and they said it's not pass or fail, but measuring as you grow. And you can think about this as actually measuring to grow. So your measure should be actionable. And again, as I mentioned before, you want to look at your measures as a whole to see what story they're painting and to see if there's any gaps or any areas that are not measured. The next slide, some key considerations for data collection. So it can be a very resource intensive process. So wherever possible, you should leverage existing data sources, and there's a lot of data being collected as already. So an example might be adding a flag for patients enrolled in the program, or a special project, or using a special projects field in certain databases. And again, build the data collection into existing work wherever you can. You want to think about incorporating verification. So for example, if you're looking at wanting to know whether appointments are scheduled, you might use a field that shows the date of appointment rather than a checkbox, because you're more likely to get accurate information from that. You want to think about frequency, so whether it's episodic or continuous, and you want to think about, when designing it, data extraction, and work with IT and decision support, and work with them early on to make sure it's as seamless as possible. So on the next slide, I want to touch on, last but not least, stakeholder involvement. Now, this is really thinking about who should be at the table, and it's both in terms of selecting the measures, but also in using them. So a few key stakeholders might be patients, families, frontline staff, managers, directors, and also those who collect the data. Again, these people are really useful to have involved early on, but also involve them in how to see how this data is being used, and so that they can see the full cycle. And I would encourage you to reflect on who's been involved in your own process to date, and is there anybody else that's missing or that should be involved to really make sure that we have meaningful measures for the program. And then really just to highlight, when you're engaging stakeholders, ideally you want to come up with general agreement and on some key overarching pieces, such as what is effective implementation, what is quality performance, and what would indicate success. And then last slide for me, I do just want to highlight some good resources that are out there. So again, as Walter mentioned, we have on the HSPN site, there is a logic model webinar that you can access, and also a development guide that can take you through step by step how to build a logic model. And this webinar that we're doing now will be posted online. RISE, or Rapid Improvement Support and Exchange, does have some great resources for OHT, and in particular related to this topic, they have a brief on data analytics. And there are also a lot of other great resources on logic models. One that is particularly relevant for this group is one by HQO. So thank you very much.
That's great, Kaylee. And I think we're seeing some helpful thoughts come in along the way as well, and considerations and questions. We've opened it up. We have a little time, a few minutes. We are going to have more Q&A at the end with all of the participants in today's webinar. But if you had specific questions for Kaylee, I just want to create an opportunity for people to ask. And if you are going to do that, we request that you use the chat box and all panelists and attendees rather than the Q&A. We're monitoring one space, and we like it to be the common space where everybody can see the other thoughts and questions, because we can share. And you can see there were some comments early on about many people are going down the same line, and there was a comment around all inventing the same wheel. Well, I think they'll look a little different in the different contexts. How you actually go about implementing the resources that are available to teams in different contexts will vary, but I think overall we're intending to head to person-centered population health care, and that is a very common goal. And that's why we also bring everybody together each month for this purpose, around sharing knowledge and learning from each other, because there are many people involved in OHTs, and there's a lot of expertise in the models. Okay, we have a few questions now that are starting to come in, and I will put off to the ones, Kaylee, that I think you're best answered, and I'll try and pick up a few. And now they're coming in fast and furious once they start typing. Okay. So does ministry expect a logic model? I don't think there's any specific expectation by the ministry as a requirement around logic models. However, we are supporting evaluation. We're responsible for a central evaluation, but part of that is supporting all of the OHTs to be able to evaluate locally, to understand, are you achieving the goals that you have set out to do? And are your plans for how to achieve those goals working? And in that regard, the logic models are a very helpful step for you to think through your program theory and say, if we were to undertake this activity, how is it that we're really going to achieve our outcome? And I think that alignment is sometimes not considered. People are very busy getting things in place, activities in place. Okay, we're going to have a coordinator, but if we haven't really thought about what the coordinator is going to do, we may not be able to improve access for people with mental health conditions to care, if there isn't a clear line for how that coordinator would ever get connected with those people. And that's part of our goals here. We are going to talk a little bit. So when partners within the same OHTs use different EMRs, and maybe they don't even have data analyst or decision support. So I think that we're going to learn from Southlake, and I think how they built it in with varying capabilities. I think they did have some backbone in their hospital, and you'll see how to leverage that. And I would suggest that, if your resources are simpler, then be simpler, but don't make this a massive manual process. We will be undertaking, I think, a few other sort of sidebar pieces of advice, and you want to build this into your workflows. And I often say to teams, if you intend to do this and you think it's important, how would you know if you're actually doing it? And if that's an important outcome, how would you know if you've actually achieved that outcome? And I think that's really at the core what we're asking for you, and what we're hoping that you will ask for yourselves. We are going to be generating, so part of the work here is we're happy to support all OHTs. We probably won't be able to support individual logic models in each OHT, because we think each OHT will have many logic models for each program. This is one avenue for support, but the other is through community of practice, where we can break into smaller groups and have little workshops along the way on building logic models, and a bit more interactive. And then we can actually probably get to the point of individual reviews on OHTs, and also leveraging expertise. We are not the only evaluation people with some knowledge and expertise in evaluation. And this last suggestion by Jim around a central repository for shared logic models and measures. I think that's a fantastic idea. And I think that's what would generate through a community of practice, is to have a place where people can look. Because one of the things, even when we were doing the model back in February, there are commonalities, but then there are differences. And so being able to leverage those commonalities and doing that work.
Yeah, I'll just say I think that's really great that people are interested in sharing, and there's such an opportunity for people to learn from one another and really think about your logic models as a work in progress too. So, you know, feel free to share while it's still in development, because there's an opportunity to learn from others.
I wonder how you'd react to this question, Kaylee, from Diane McKenzie. Diane from McKenzie OHT. Challenge: how do you attribute impact if the model or understanding of the program isn't specific enough to determine?
Yeah, attribution and contribution can be a real challenge, especially when there's so many things going on in the system that influence health. So I'd say I think the logic model is a real starting place if you're going to be able to show your contribution. And it might be that you have a broad overarching look at it that really explains the full program. And maybe there's certain parts of it that you want to drill down on and get more specific to see exactly what are the mechanisms that are getting you along the way. So that sort of dual option might be one approach at digging deeper without taking all the resources to do it for the full program.
Okay, and thanks, Kaylee. I think we're going to move on now. And I'll just say, how can people follow up? And we're going to have more discussion at the end of this session, follow up on more of the work to support. Send an email to oht.evaluation@utoronto.ca, and we'll be back in contact. That's the best way to contact us, is through our central group. And we're really happy now that we're going to have our colleagues from Southlake join us. And Judy, Gail, Margaret, and Jennifer are always all coming online, and you'll be able to see their videos coming up. And we're going to welcome them to our webinar. And I think without further ado, we will let you take the floor.
Thank you, Walter, and thank you, Kaylee. And from the Southlake Community OHT, we're really thrilled to be here and share with you our journey working with logic models and measures. We are in the early phases of our journey, that's for sure. But I'll just walk you through a little bit what we thought we would share today. To start with, we're going to do a very, very quick scan through the logic model we were using, then share with you the measures that we are using and also why we think these measures are important. And then what we're going to do is we're going to move into what I think is the heart of how our program is being able to really help the residents in our community, and that is our patients as partners. And Judy Smith will be here to speak with that. And also our champions group, which is really the engine of Southlake at Home and our community OHT. And we'll have Margaret Furman from SE Health, Jennifer Andrachuk, who is a physical physiotherapist at Southlake Hospital, and Judy joining in that conversation. And finally, we'll bring forward a bit of a challenge that we're having, because sometimes not all of your measures go the way that you hoped. So if I can ask for our next slide, I'll just quickly orientate you to our Southlake, our logic model. And one of the things that you will notice is, unlike Kaylee's logic model, ours is reverse. And that is because we started with understanding what we wanted to accomplish. Then started to look at how would you define that? How would you align measures with those outcomes you were looking for? What activities would you need to create those outputs? And what inputs would those activities need? And we found this was really a great tool when working with many members of our community, because by gathering everybody's thoughts about what we wanted to accomplish, that gave us a really good starting point. So if I can just have the next slide, talking about our measures and what measures are important. I think a couple of things regarding our model is important. And one of those things is that it is population-based. It is not disease-specific. We have tried to make it as low barrier as possible. So for all of those individuals who could be best suited for that model, that they can access this service. We also want to be able to integrate care at the point of care and looking at using the resources that are already available in our community, but having those resources work together in a very different way is one of the key elements we want to measure in our program. If I can have the next slide, please. So one of the things that you're going to see on this slide is really understanding how the resources that are available in your community can work together in a new way. How do you measure that? How do you know by working together that you're actually achieving the outcomes? And what is really critical for us is having patients as partners to do this. Because what happened in the beginning is patients told us what they wanted. We didn't go to them with a menu of this is what we can offer. We started the conversation in a very different way, and that heavily influenced what our outcomes and our measures are. If I can have the next slide, please. You will see that we started with a very, very big and challenging goal. We don't want anybody to be waiting in hospital when they can be better cared for in their homes and in their community. So to achieve this, we needed to put that right out in front and then build everything around and from that. One of the things we also needed to do at this point was take a deep dive into our data. So we had our patients telling us as partners, we had our providers telling us many things, but we also needed to take a deep dive into our data. And one of the things we learned is there was a belief that because our community is rural and suburban, that most of our challenges related to rurality. When we looked at our data, we found out the exact opposite. In fact, most of the people who were being caught in this ALC situation actually lived within a few kilometers of the hospital. So if we can move on to the next slide, please. This meant we really needed to understand what are the things that are impacting people between you want to go home and you're not going home. And you can see that the key elements there, that being trust, customized care plans, no eligibility criteria. So we had needed to be able to develop measures to actually say, were we achieving these outcomes? And when we did start to measure these things, did that reduce the barriers? Did we see that big goal of ALC days actually coming down? Or did we take out a barrier, which is wonderful, but it actually didn't have a relationship with the outcomes we were wanting to achieve? So moving us on to the next slide and talking about outcomes. Here you can see that if you want outcomes, we had to develop many of the tools so that we could measure our outcomes. And we also wanted to make sure that the outcomes we were looking for and the measures that we were measuring were in balance. So we looked to the quadruple aim because that is a great template and it allows you to have that balance, understanding what the patient experience is like, what the provider experience is like, what type of clinical outcomes you're getting, and also how is that impacting how the health system functions, or what are the benefits to the health system. And I think this is really important. And I would share with you that in our early conversations with all of our stakeholders, having this framework and explaining the importance of the balance of the measures was really important. Because every so often you'll get a team member who really believes that one measure is the really important one and that other things would need to be perhaps reduced so that that measure can be achieved. And so that's where having this framework and understanding the balance of measures was really critical. So I'm now going to move us into, next slide, please, into really the important part about how this program has worked and what is most important. And our team is going to give you two examples to explain our experience. Our first example has to do with the scheduling of visits, and that was something that we tackled early on. And then later, we're going to come back and we're going to talk about one of our new challenges or one of our new changes in metrics, which is the 7-day primary care follow-up. As you can see for this slide, we continue to look at the success, the tools we're using, and really making sure that what we're measuring is aligned to our outcomes. When we're not getting the measures that we expect, what does that mean? And again, going back to the large community that makes up our OHT so that everybody is able to participate in this data, the outcomes and the measures that are happening. So we're all speaking a common language and using our logic model and the measures to help drive us to our common outputs that we are hoping for. So I'm now going to turn this over to a really, really critical member of our team, and that is Judy, who is our patient partner. And Judy is going to speak about the role of patient partners. And I know if you've heard Judy speak before, she is extremely engaging and has been such a critical member of our work here at Southlake. Judy?
Thank you, Gail, and thank you, Walter and team, for inviting me to have an opportunity to speak about the critical role of the patients and the families as partners in their care. And truly, this program, the Southlake at Home program, is that type of partnership. It started very early on, and my role at the time was that of a family advocate for my mother-in-law, who was one of the first people enrolled in the program. And I have to say, from the first touch point, Rita was asked what her goals were, what she needed. And as Gail said, she lives very close to the hospital in a retirement home. And then they followed up with me and asked if I could help them with some outcomes. Excuse me. One of the first things we were told was equipment was going to be delivered prior to her discharge. And having worked before in the healthcare field, sometimes equipment arrives, sometimes it doesn't. I was shocked when I got a phone call from SE Health to say the equipment hadn't arrived, but would be there before she left the hospital. The other thing that shocked me at the time was I was told she was going to have her first visit within a couple of hours of discharge by her nurse care case manager. The case manager phoned and said, would it be convenient for myself and my husband to come over and be present during the assessment, which was what Rita had asked. And she was actually there 2 hours post-discharge to start developing that holistic care plan. Trust was built up and it was ongoing. Rita was asked what was her goals of care. And she's kind of shocked people. Well, number one, she needed to be able to walk to the dining room because she lived in independent living in a retirement home. But her main priority once she got home was she needed her hair done the next day. And it was amazing. They said, okay, we'll make sure that the nurse is here to get you up and dressed before it's time for your hair appointment. We'll make sure to schedule visits around that hair appointment and make sure that you get back. That was just one example of listening to what the patient's needs were. The program has 2 patient family surveys that are done. One is a transitional survey, usually done within a week or 2 of the patient leaving hospital and going on the program. The second one is done post-discharge. Very similar questions, but again, speaking to what was the patient experience. At the end of Rita's journey, and she met all of her goals, we've completed the survey, but I felt it was such an important program that I actually approached the hospital and said, I'd like to become a patient family advisor, and was snapped up by the program to work on working together. So far, the program has asked all 270 patients how their journey was. And now as the patient family advisor, I sit on the other side of the fence as a member of the steering committee to actually look at what are the responses. And not only the ones that are great, but also taking a look at the ones that need some work. And that's how we drive this program forward. And Margaret and Jennifer are going to talk a little bit about the work that is extremely important at moving the program forward. But on the front end of the patient and family, we had no idea what was going on. The champions group meets regularly, and they are the people that drive the program based on the feedback from the patients and the families.
Right. Thank you so much, Judy. So I wanted to build a little bit on the example that Judy mentioned about improving patient experience. And I was asked to share our response to a feedback that we received from our patients or caregivers around some challenges they've experienced with their ongoing scheduling. So Judy mentioned how very initially things worked very smoothly in terms of the first visit, but what we got feedback back on is how our ongoing visits are being managed. And through the patient experience survey post-transition to home, we learned that some patients have experienced challenges with their ongoing schedules. And based on that feedback, we've implemented a number of processes pretty quickly. One of them was a fairly low-tech solution that was quite effective, and one that was a bit more techy. So for our low-tech solution, we've implemented a paper calendar that is left in the patient's home, where our staff, our interdisciplinary team, can write down their upcoming schedules, and also the patient and caregivers can write down any upcoming medical appointments or planned outings. So that really allowed us to improve that communication. In addition to that, we've implemented a web-based application where those patients who opted to participate could, through a secure portal, access their upcoming scheduled visits. It was a one-way view, but they were able to view their upcoming visits. And this was particularly well received by caregivers who were not living with the elderly patient, who were very concerned about them and wanted to be very involved and included. So through these mechanisms, as well as ongoing communication, we were really able to move the needle on this improvement opportunity that came directly from our patient experience survey measures. And this next slide really shows you the engine, as Gail mentioned, that allows us to keep an eye on the goal and use measurements for quality improvement, and that is our champion group. This group was established before we took our first patient and is still very active, almost a year and a half after we've implemented the program. It really allowed us to fundamentally rewire how we work together, as Gail mentioned earlier on. And this champion group is comprised of representatives from each provider organization, from community partners, as well as hospital staff, and we meet regularly. How do we function? We discuss feedback from patients and families to guide quality improvement. We review data and feedback from partners to monitor outcomes. Through ongoing checkpoints, we share learnings, problem solve together. This really allows for that collaborative co-design with our patients, with our caregivers, and with our healthcare providers. We really create a team culture that welcomes transparent dialogue about what's working well and what's not working so well and can be improved. Our patient and family advisor committee members are key participants and participate as full and equal partners. And along the way, from the very beginning, we were encouraged to think differently, to challenge the status quo, to break silos, remove barriers, really daring to think outside of the box while keeping that end goal in mind. And so key messages is iteration and learning. Work with patients, families, caregivers, and other partners to continuously learn and refine your program design. I'm going to pass it on to Jennifer to give you some experience from her end on being a participant as a champion group member. Over to you.
Thank you, Margaret. So my name is Jennifer Andrachuk. I'm a physiotherapist at Southlake Hospital and part of the Southlake at Home Champion group. I just want to say it's been an honor to be part of this group to help design and develop the Southlake at Home program. As Judy and Margaret have both mentioned, scheduling is a big component of this care plan with Southlake at Home. From an allied health perspective, from a frontline perspective as well, we have the confidence when discharging a patient home on the Southlake at Home program, knowing that they're going to receive the appropriate care and equipment they need to have that successful transition from hospital to home. And if I could just give an example, so in the past, if I had, say, referred a patient for home physiotherapy through the LIN, they'd be assessed and maybe be approved for 6 home visits. Whether the patient actually required those 6 visits or not, that's kind of the blanket number they were given. With the Southlake at Home program, the allied health from the hospital provide a discharge summary, which we developed as part of the championship group, to the home care providers. So they know what the patient's care plan was in the hospital, and they know what their goals are going home. They're also, as Judy mentioned, provided equipment before their discharge for that successful and safe transition from hospital to home. The nurse will meet with the patient within the first few hours of them being discharged, and the other allied health team members meet with the patient soon after discharge as well. What we love as an allied health team is that I'm just going to use physio as an example right now, that if the patient is, say, weaker at the beginning of discharge, they may need more than one visit a week, and that physiotherapist is able to help determine that patient's care plan, and they reassess regularly. So in the beginning, they may need 3 visits a week, but as they become stronger, they can tailor that need, that they might now only need 1 visit per week, and they might actually, their care needs may be somewhere else. And the Southlake at Home program is able to help direct that really patient-centered focused care to meet that patient's needs. So I think from allied health, we have that confidence with this program, knowing that with that flexible scheduling and that big equipment piece has been a huge part in helping us plan discharge from the hospital.
Okay, well, thank you very much. And I think that gives you a real example of the great work and the measures and our logic model that keeps us moving together. But if I can ask for the next slide. Sometimes things don't go quite in the right direction. So what you are seeing in front of you is our report, our scorecard that we produce on a monthly and quarterly basis. And as you will notice in the lower left-hand corner, our ability to connect people within the first 7 days of discharge with primary care has dropped to 85%. So to give you some context, this measure had been at 100% almost for the first year of the program. And then something called COVID hit. We're not even sure if COVID's related to this, but what we did notice is that this has slipped. And as our champions group started to explore it, it's important to bring in all of the different perspectives of why this is happening. So we know that during COVID, many primary care individuals moved to virtual care, and that can be seen as quite an asset. And in fact, in our OHT, we are continually encouraging the use of virtual care. But one of the things that we learned was through our patient survey, when we were talking to someone and they were to have their follow-up with their primary care and they didn't attend it. And the answer was, can you help us understand why? And one of the reasons that they said is that, well, I'm hard of hearing and I read lips. So by doing virtual care over the phone, it's really hard for me to participate. I don't quite understand what's being said, and frankly, I get frustrated. So that was just one example where we said, oh, that's interesting. And working as a team, we're able to say, well, do you have access to an iPhone or a technology, a tablet, and anything doodaddy that we could do a virtual conference with your primary care provider? And by making that small switch, understanding the perspective, primary care, when we talked to them, said, oh, I didn't think about using an iMessaging system or some other technology that's readily available. I'd always just thought of the phone, but I understand your point. So that's an example of how we're understanding this metric. We're also understanding that office hours and the need of PPE for primary care through the COVID has changed. And frankly, some of the participants in our program have said, I don't really want to go to the office, so I didn't keep my appointment. Well, did you know there's virtual care? And as one fellow said, I don't know what you mean by virtual care. And so again, sometimes that's about our language and explaining that you could have that visit with your primary care practitioner via technology, using a simple phone, whatever. So we're not exactly sure all of the elements that are driving this measure to be at 85%, but we do know by working as our patients as partners and bringing back our surveys, both our provider surveys and our patient surveys, and all of our data to our champions group, that we are going to figure out what are the points that we need to pivot and change our program so that we can get this back up closer to 100%. As you can see here, as I mentioned earlier, we do continue to categorize our data using the quadruple aim of the IHI. You can see that we are looking at patient outcomes. We are still driving for 0 ALC days for home care. I think we're getting very, very close. We're probably in the neighborhood of 0.8 right now. We want to hear about the patient experience. And one of the things that Judy and our other patient partners have been able to really help us is understand. We took the original patient survey the hospital and our partners all use, put those together, and then we ran it through our patient advisors to say, how would you reword this survey so it's meaningful for you? So we are asking questions in a way that people actually understood what information we were trying to retrieve through those questions. You can see our provider satisfaction. One of the things that the Champions Group and our team is most proud of is the fact that our personal support workers are strongly indicating that they feel they are part of a care team. If you're familiar, sometimes as unregulated providers, the personal support workers aren't always invited into the conversation, but yet we know that they are such critical members of the care team to truly understand what's happening in the home. Some of the value moments you can see is that I think it's a little bit closer to 2,000 days, a little over 2,000 days of ALC have been avoided. And now for the first time, we're actually seeing a reduction in our total ALC bed days, meaning hard green dollars just versus light green dollars for those who do the accounting end of healthcare, which is really, really exciting to see. What we're also seeing is that for individuals who might earlier have been admitted to hospital just so people had a chance to get organized and figure out what's going on, these are people who have subacute or emergent issues that could be managed with primary care and other supports. We've actually been able to support 14 of those individuals to go home from our hospital. So if I can just ask you, Walter, to move us to our last slide. That is one of our, as I said, one of our placemats that we do that we do share, and we bring this to our champions group. We have a number of other measures we look at, but to Kaylee's earlier comments, sometimes if you're measuring a whole bunch of things, it becomes really hard to keep everybody focused. And over time, we are anticipating that what we see right now in front of you is our key measures, that some of those, once they become almost a standard of how things are done, may fall off the report card, and we'll bring another measure to the forefront that we're really working on. So in our journey at the Southlake Community Ontario Health Team, you can see that we started with a logic model, did it in reverse order, really focused on having measures that were very important and meaningful to the work that we are doing. It's not to say that we ignore the larger measures that the ministry has put in front of us. We certainly do keep an eye and focus on those also. But we're really wanting to understand, is the work we're doing actually achieving the outcomes and having the impacts that we wish it to? And so far, all of our indicators are that we are on the right track. We certainly have a fair bit of learning and a journey to go, but we believe that we're on the right track. So from all of our group here at the Southlake Community Health Team, Southlake Community OHT, all of these acronyms, I tell you, that is where we are in our journey, and we are absolutely thrilled. And thank you, Walter and team, for inviting us and giving us an opportunity to share our journey.
That's great. Thanks so much to Judy, Gail, Margaret, and Jennifer for bringing that to light. And so we're going to have some time now to ask questions of this team, but also questions might come up to Kaylee. You're getting some shout outs online from some of our audience today. And we're interested in the audience's thoughts around contributing in the chat. Remember to text to all panelists and attendees so people can see questions that you might have for Gail and their team, and also questions that you may have for Kaylee or us. And I'm going to bring it off the screen share so we can actually see each other here online and have a bit more of a discussion at this time. There is a question that came up around the reporting. So just at the very end there, you had put up a dashboard, and I wonder if the dashboard all come from, so how much work is involved in creating that? Does the data all come from the same place? How complicated is this?
Well, it's a little bit more complicated than it might appear on the dashboard. And some of that, if I can just go back to Kaylee's comment about primary care visits within 7 days and being able to pull that from your EMRs of your primary care partners. That works absolutely fabulous when your primary care partners have EMRs. But when your primary care partners actually are still on paper charts, it's a bit more difficult. So what we have done is we've used a measure of nurse-reported outcomes. And so the nurse case manager that Judy and Margaret mentioned actually report on that indicator because we can't always get that information from our primary care partners. We also measure that indicator a slightly different way, and that is with our patients and their families to ask if they're participating in those conversations with primary care. Because we not only want to know that that important 7-day visit is happening, but that people are participating and continuing on their healthcare journey.
Thanks. And just while we're waiting for other audience questions to come in, I'm gonna go to Kaylee and bring Kaylee into the conversation, because Gail also ended up, and there was a comment in here in the chat around the comment around starting in reverse ordering was how Gail put it. What do you think about that, Kaylee, this reverse ordering?
I think it's a great place to start, because really the logic model is trying to communicate the program goal, which is really starts at that impacts and that outcome piece. And we always want to be having that central in terms of our vision and what we're trying to achieve. And then it's a great idea to work back on the other pieces in terms of how we're going to get there. So yeah. I really like the style that was presented there.
And I think actually it lines up with the way we're thinking about supporting logic models and what other people should do. We actually do think that starting with where you want to be, and then think about what do you need to do to get there. And in fact, I think on some of our other work, we've sometimes said the outputs, that thing that gets counted, because it can be counted, may actually be the last thing you put down on the page. If you think about what are the things where do you want to get to? What are you going to have to do to get there? I want to know, Judy, I mean, you really bring in the patient and caregiver voice here. I think it's really important. Thank you for your contributions. Very representative, and there's some clear shout outs. I don't know if you saw the chats for your engagement here. Are you alone, or do you have lots of other colleagues and friends involved in the as patients and caregivers and input? I just wonder, some people are talking about putting people on subgroups and subcommittees about how they involve, and I just think, they have some limited resources. How?
I actually have a partner that sits on the steering committee, and Southlake itself has over 80 patient and family partners across the hospital. And not only that, but we also work with the patient and family partners of our community partners. So no, I'm not alone.
That's great. And I didn't actually know the answer to that question before asking. It was a bit of a risk question. But I'm glad, because I think that one of the things we need people to understand is we do need, just as we have multiple providers, we have to be cognizant of the tasks and burdens that we ask of patients and caregivers. And while it's great to have excellent engaged individuals like yourself, Judy, we also need to have many points of contact, I think, along the way.
And I think that, Walter, that's one of the exciting things of the Southlake Community OHT is that part of the patient and family are actually members of the anchor group. And there is a separate group that will be up shortly running with advisors from all of the community anchor partners.
I think that's also great in sort of building a community amongst yourselves, right?
Yes.
I wonder, I think maybe I'll talk to Julia Abelson, who's interested in supporting OHTs and patient engagement, about creating communities of practice to support patients and caregivers in engagement, amongst others. I've got, you're getting, there are some comments coming in. If people have questions, I encourage you to make sure you type them into all panelists and attendees. I don't see them if they go to the Q&A, so put them in that chat. Margaret and Jennifer, I wonder if you can comment, when you're looking at, have your champions group and they're meeting and you're working out problems or looking at data, how do you have the opportunity yourselves to contribute to how things are going to be done differently in delivering care? So if somebody isn't being able to be seen quickly enough, how are your contributions or your thoughts? Do you feel that you have the opportunity to contribute to those solutions?
Mm-hmm. So that's an excellent question. Our champion group is really representatives from the various partners, really starting to look at the problem. But once we identify a problem or something that can, be improved on, we take it back to our teams. And for me, being an operations manager is really important to bring this back to our frontline team, to be able to engage in solution. And then to continuously work with the champion group to, kind of enable those solutions if it needs to be enabled through that champion group, or basically come up with processes that can be improved right at the front line. So all of these measures really, really important to cascade them down to make sure that our frontline staff are interacting with them, that it's not just a measure, it's not just a metric, it's not just a number. What is behind it? What's the reasoning behind it? Why is it important to our patients? So that's one way that, that we do that through the champion group.
Yeah, and I'd like to add to that. So being a frontline team member, and again, meeting with all of Allied Health, and I meet with them very regularly to ask them what is working well with the program, what maybe isn't working so well, and what would they like to be, like if they have any changes that they'd like to be seen. And I find that when I bring it to the champions group, there's no idea that's ever turned down. Everyone's very open to listening, and the goal is really to make this about the patient and the safest way that they can get from hospital to home. So I've never felt that any ideas or even, maybe constructive feedback that I've gotten to the team has been looked down upon. Everyone really works together to figure out what can we do to improve the patient experience and really make it effective and safe for the patient to return home and stay in their home. So it's been a really lovely experience where everyone listens takes the feedback given and we kind of think, okay, what can we do differently, or how can we prevent that from happening again? And I find that it's a fantastic team approach.
Super. That's great. And I think you're getting some comments around bringing things to the front line to help create those solutions. So I'd strongly encourage that activity, because it is, so far, I think many of the OHTs are still in the planning phase at a more administrative level. And when we've been talking to providers out there in the field that know about the OHTs, it hasn't quite landed yet. So just in the early days now, as you're working ahead towards your OHTs, to really think about how are you going to create, how are you going to understand your logic model, how are you going to think about measurement, and then how do you bring that back to a group that can actually take action. And I like to tell stories of failure from our end. You know, Gail has shared something where they've been challenged. Here's something where we've been challenged at the Health System Performance Network. Years ago, we were concerned about not having data quickly enough to be able to provide feedback to the teams. And so we created, and we're participating in an initiative where we managed to have essentially real-time patient experience data. That after a given appointment or at any time, patients participating in the program had tablets, and this technology enabled them to answer a couple of questions around their most recent provider encounter, and if it had met their needs, or a couple other experience questions related to that, co-designed with patient input. And we had this, as soon as they entered the data, it was in the cloud on a data set. We didn't report it back quite that quickly. We thought, well, maybe a constant indicator, but what we decided to do is that weekly we would report this back so we could create a focal point around looking at the data. And so Monday mornings, we'd put out our Monday report, and we had data from experiences from patients on Sunday. We could have had it from Monday morning, but we had it from Sunday, and it was from the week prior leading up to that. And it was really the fastest. And we gathered this together and we sent it back to the project team, which was made up of project management type people. And we'd send it every Monday religiously, our Monday report. And then we checked in after about 6 weeks or 2 months of doing this. By that time, we were close to halfway through the project of the data reporting side anyways. And we're like, so what are people saying about the data? Like, what did the frontline providers say? What did the providers upon which, this experience data? They're like, oh, well, I don't know. We haven't shared it with them yet. And I'm like, well, how are you using the data? And like, oh, well, we use it all the time. We're looking at these indicators every single week with our project management team. And I'm like, and what do you do that can impact upon those experiences? And they said, well, we work with the providers. And I'm like, but the providers don't know how the people are responding. And it was, it's a partnership to get this done, top to bottom. And actually put the data in front of the people that it can actually make a change for is one of the more powerful things I think that Southlake has done here. And kudos to you. It's not easy. It's not easy to create the bandwidth. I don't know, Jennifer, how you get time out of your day to attend these meetings. Because, I always think when we have a provider, we're taking time away from patient care. And so we really need to make sure it's valuable. So I commend you on that work. And I don't know if any of you have any thoughts just to close out on your experience of, I think, actioning the data beyond, I really appreciate you're doing the extra work in the measurement, and that's why we brought you here, but we've learned over time in talking with you about how you actioned the data. Maybe we'll go through one time, Jennifer, and then Margaret, then Judy, then Gail to wrap up.
Yes, thank you. So just to quickly mention, you're saying, being a frontline staff, I do work on a busy acute medical unit, but I've had great support from the hospital to be a representative on this championship committee. So I've had fantastic support from the hospital. I'm really proud to say that about Southlake.
So what I will comment on, just to kind of to my earlier point about, ensuring that this champion group is a representative group, but then the people who actually are interacting with patients, working with patients on a day-to-day basis, our frontline staff are really involved. And I think because of this champion group, I was challenged to make sure that I'm bringing it back to my team and involving whoever I need to involve from my organization as a partner and making it really meaningful to our staff so that they can participate in meaningful solutioning. I think that's really powerful.
Great. Judy, any final thoughts and comments?
I think the most important thing that I can come up with is to engage whoever is working on your team as a patient family partner and listen to how they're feeling and make them feel a valued part of the team and not just by namesake. And that's the one thing this program has done for me.
Thank you very much. Great words, and thanks, Judy, for really taking the time to join us here today. Gail.
At Southlake, we have a strategic direction that talks about the power of many. And I think that to the point about your point of care staff and people having the space to have these conversations, that's really about the power of many. And to your earlier comment, Walter, about, if you just have a couple of project people exchanging numbers and having a dialogue, that's like 2, maybe 3 brains. Maybe if you've got a big team, you've got 10. But if you look at it the other way and really be inclusive and make sure that every voice is elevated and included in those conversations, instead of having 2 or 10 people, brains working together, you can have up to 100, maybe 1,000 brains on some of the larger projects, all focused on getting to the same type of outcomes and making sure that those outcomes are important to the people who are receiving and providing the care. So, I can speak to this because Jennifer actually works in part of my area. And that's one of the best investments I make every time Jennifer goes to the Champions group. The ripple effect through the entire hospital and through the community and working with our providers and our patients and families, it's just exponential. So I get the question about the investment, but what I would say is the payback is so much larger. It's well worth the investment.
Well, thank you very much, and thanks to all of our panelists today. It's really been a pleasure today. You will see in the chat that we have now added up a link for feedback on today's webinar, and we'd appreciate if you could take the time to join in there. And hopefully you learned something today. I'm going to skip past that poll due to the timing. Just to let you know, every 4th Tuesday of the month, we gather together in this forum from 12 to 1:30. We now have 2 of those topics that we talked about in September. And up in the new year, we won't have people come in at Christmas. Up in the new year, we're going to be looking to evaluation measures. We have measures coming forward on system level measures, provider level measurement, patient level measurement, and ways to think about and approaches to undertake population health management and more beyond. So welcome, everyone's involved. Feel free in the comments section of the feedback form. We will also email it out to everybody. Other suggestions for future webinar topics we're planning out now for next spring and summer. What do you think you're going to need, or what are some of the assets and resources that can be made available? Again, thank you very much. Really appreciate everybody joining in today, and have a great afternoon.
Thank you.